This is the second part of the acid-base disorders lecture, and here we actually are going to take a look at the respiratory and metabolic acidosis and alkalosis. The information that's in your textbook is very good, very thorough on this, but not necessarily very lengthy. So I strongly encourage you to read through all of the information and pay special attention to the tables particularly the tables that list the manifestations for metabolic acidosis and alkalosis and respiratory acidosis and alkalosis. Those are really important. When we did the fluids and electrolytes, I told you didn't have to concentrate so much on the manifestation tables, focus more on the function. In this case, though, it's quite the opposite. You really do need to be familiar with the manifestations. And this is another one where you can't quite memorize that list, but you've got to take a look at it and go, okay, why are each of these manifestations happening? Again, the book and the way it's laid out in the book does a really good job of explaining that. So please take some time to read through, particularly when you get into the point where it starts talking about the actual disorders. The disorders actually begin on page 195 with the disorders at the very bottom of the column with the disorders of acidosis, and it talks a little bit about compensation, but when it actually gets into the conditions starting on 197 with metabolic acidosis and then working its way into metabolic alkalosis and then the two respiratory disorders, it's not a long set of information, but it's really well laid out, and if you take the time to read through it, I think you will find that it helps make sense. So when we start looking about acid-base disorders, again, we are talking about something that's either metabolic, which involves bicarbonate and is being regulated through the kidneys, or it's respiratory and it involves partial pressure of carbon dioxide and it is regulated through the lungs, hence respiratory. Now, acid-base disorders have what we refer to as a primary or initiating event, and then in some cases a compensatory or adaptive event. So the primary event is what really went wrong first. What's really causing a move away from homeostasis and causing them to actually have a metabolic disorder where the hydrogen ion concentration or the bicarbonate concentration has gone awry. Again, remember, you can have a change in bicarbonate. The bicarbonate level can drop low. The hydrogen ion level may not change at all. Bicarbonate drops low, and suddenly you are in an acidotic state, but you didn't actually get any more hydrogen ions. It's just that ratio, that balance is lost. So something initiates or causes it. That's the primary event. And then the compensatory event is what the body does to try and control it or correct it or bring it back to normal. And what we see is that if we have a respiratory event as the primary event, we look to the kidneys, a metabolic compensation to take place. Now, it doesn't understand that the body function is not static. It is constantly changing. So depending upon where the patient's at when you're evaluating and testing them, they may be in a respiratory acidotic state, but the kidneys have not yet initiated their compensation. So there may not be compensation, or there may only be partial compensation. Hasn't actually brought it back to normal yet. When you looking at the arterial blood gases, which we did in the previous lecture, when you take a look at how to do those, what you're really looking at is what kind of compensation is actually taking place. And in fact, let me bounce back to that, was where we left off on the last lecture. When you're doing, in this example here of an arterial blood gas, what you had was a respiratory acidotic state. You have a lower pH, you have high carbon dioxide levels, which means you have a lot of free hydrogen ions being formed, and you're in an acidotic state. And what you look to then is the kidney compensating. Well, the kidney's normal right now, so it has not begun its compensation. It may have been moving up a little bit because 22 to 26 is normal range, so it's at the upper end of normal. So you may be seeing more bicarbonate being retained, and eventually this number we check it again in 6 hours, and we find that that number has actually increased, and we start to see some partial compensation going on here. This becomes more alkalotic and is trying to compensate to try and get that pH back into a normal range. For the sake of our class and what we're doing with arterial blood gases, we're not ever going to see full compensation on a table because I'm trying to let you see the process along the way. But it is entirely possible for you to run something like this and the pH actually is in a normal level, so we don't list it as acidotic anymore because it's being compensated, but we see both of these out of whack. So that test has less value when it's fully compensated because it's more difficult to determine, well, which was the initiating or primary event. So as we look at arterial blood gases, when you see them on the exam, they will not be fully compensated. There'll either be no compensation, in which it's normal, or there'll be partial compensation, an attempt to try and bring it back to normal, but we aren't actually there yet. Just recognize that sometimes oftentimes it does get there. The arterial blood gas test doesn't have the same value then at that point. All right, so understand we've got something primary going wrong, and then we have the compensation. Metabolic is the term we use for the kidneys regulation of bicarbonate, and respiratory for the regulation of carbon dioxide of the lungs. So, looking at metabolic acidosis first, the primary problem is if it's metabolic, it's a primary deficit of bicarbonate or an increase in hydrogen ion that causes, either way, we have a drop in pH. So it isn't actually commonly a primary disorder. It usually isn't the thing to go wrong first, but it can occur from increased production or ingestion of non-volatile acids. So this is in some way a high protein. If you're on an Atkins diet, for instance, a high protein consistent diet can be a problem. Kidney failure is probably the most common problem that may lead to this disorder. For some reason, again, this can be kidney failure is inability to get rid of the hydrogen ions, and so that concentration increases. Or something could be going on actually at the kidneys where you increase bicarbonate loss. Or you could have excess chloride ions, then you would move into hyperchloremic acidosis. That's an issue with the anion gap. And again, you can look at chart 8.2 to see that. It's actually in your book on 197. Manifestations are listed in table 8.10 in your book. I actually think the page for that is 198 in the current edition. Just so we're clear on that, I'm looking at the 4th edition. So there's a lot of manifestations listed there for metabolic acidosis. Lots of GI issues, anorexia, which is loss of appetite, nausea, vomiting. The nervous system effects are profound, weakness, lethargy, confusion, can even lead to coma, cardiovascular effects. There's a lot of peripheral vasodilation and a decrease in cardiac output. The heart function decreases, reduced cardiac contractility. So I just listed a couple things there. Linked also with hypercapnia. Again, remember, if it's a metabolic and you have an increase in hydrogen ion concentrations, then you're going to see at ECF, ICF to shift. One of the signs of compensation that you get, remember, manifestations include what the other system is doing to compensate. So Kussmaul's breathing is a deep but rapid breathing. It's not quite the same as hyperventilation, because hyperventilation is more shallow breathing. But in Kussmaul's, you have a very deep inhale, but it goes fast. It's not a slow, progressive, but rather a rapid but deep inhale. That's the body trying to compensate at the respiratory side. So that's the respiratory compensation. So please take a look. And again, read through the manifestations that are listed there. There's a lot of detail that's in there. Don't get caught up in the detail, however, but think about the overall function. What's the body going to do if there's a lot of excess hydrogen ions? What does that do? Again, think about cardiac contractility. The heart becomes less responsive to your catecholamines, your epinephrine and norepinephrine, when there's an excess amount of hydrogen ions. It simply doesn't bind to it as well, so therefore the heart rate is profoundly affected, and you get to some dysrhythmias or arrhythmias that can occur. So the heart just won't contract as well in a metabolic acidotic state. So that's your metabolic acidosis. In metabolic alkalosis, you have an increase in pH due to an increase in bicarbonate ions. So causes, I've listed some causes here. Vomiting is one of the bigger causes. This is what the table shows here. Don't think, oh gosh, she's going to give me that table, I'm going to have to increase that all out. Not at all. But I do think it does a nice job. And this is a picture straight out of your book. It's figure 819 in your book. And so take a look at what you're looking at. It's really listing the renal mechanisms for bicarbonate reabsorption and maintenance of metabolic alkalosis following some sort of depletion of extracellular fluid volume. Particularly vomiting is the one we're showing here. So if we lose chloride because we vomited it out, we'll increase bicarbonate reabsorption. When that increases, that leads to alkalosis. I've lost extracellular fluid. Decrease, this is the glomerular filtration rate. There's renin, this is the RAA pathway, which increases bicarbonate absorption. When I have a depletion of potassium, which can also be occurring as a result of vomiting and loss, that increases bicarbonate reabsorption. And we have more, all of these things are leading to an alkalotic state. So this is how vomiting can lead to that. Hypokalemia is something that can maintain or help maintain a metabolic alkalotic state. So because we have to move potassium and hydrogen, start making exchanges, and therefore when I say maintains, it's like if you're in a metabolic state and you want to come back to normal, hypokalemia can actually prevent that from occurring. Once again, the list it's the same list, table 810. That's the right-hand side of the column, gives the manifestations. In some cases, the symptoms, unless it comes on rapidly and is extreme, can be somewhat asymptomatic. Again, compensation is going to be respiration, so you'll start having more shallow breathing instead of that deep rapid. It's a slower and shallow breathing. And hypokalemia is one of the biggest manifestations you need to worry about. It also can lead to some hyperactive reflexes that can occur, confusion, seizures. This is think about overreaction. In metabolic acidosis, we had underreaction of the nervous system. Things went a whole lot slower. Things didn't respond. Now we have rapid response, kind of a an hyper-excited state that can occur in metabolic alkalosis. In the respiratory disorders, we're looking at respiratory acidosis. These are going to be issues at the lungs. So acute, and it's always accompanied by hypoxemia. So an increase in partial pressure of carbon dioxide. Think about anything that, and that's the term, by the way, high carbon dioxide levels, hypercapnia. I'm hoping that's not a new term for you. I should have had that in A&P. But anything that increases carbonic acid or decreases pH. So high carbon dioxide levels, remember that equation, it's going to lead to a release of more hydrogen ions. So always accompanied by hypoxemia in acute states, acute respiratory failures associated with this, lung disease, chest injury, airway, anything that's affecting the lungs. Asthma, emphysema can be part of chronic compensations. The most profound manifestation in Table 811 in the 4th edition, it's page 201, have the most profound effects on brain function. The release of carbon dioxide into the cerebral spinal, or the increase in carbon dioxide, just release, but increased carbon dioxide in cerebral spinal fluid is particularly damaging. It causes vasodilation of the vessels within the brain, reduces blood flow, and so that's why you get confusion, depression, hallucinations, weakness, paralysis, can lead to coma, very profound effects. And it tends to come on rapidly due to the effects of the carbon dioxide within that brain fluids within the blood, or within the brain tissue. So really profound effects of respiratory acidosis. And then respiratory alkalosis, a decrease in partial pressure of carbon dioxide. Hyperventilation will do that. So if you're having a panic attack, excessive stress, you see it in fever, you see it in encephalitis. And if the ventilator is improper. So this is more of a clinical concern. Proper use of ventilators is extremely important for more than just the fact that it can cause respiratory alkalosis. But if you actually increase too much hydrogen and don't allow for increase too much oxygen and don't allow for the release of the carbon dioxide, I'm sorry, I'm not saying that right. In the improper use of the mechanical ventilator, what can happen is you increase oxygen levels and therefore increase respiratory rate to the point at which more carbon dioxide is lost, more oxygen is coming in, and that balance is lost. If that occurs, you actually are mechanically hyperventilating your patient, over-oxidizing the patient, so you can have some real problems. Don't think reperfusion injury, that's a little bit different, but improper ventilation can actually put your patient in a respiratory alkalotic state. The manifestations, again, tend to be more of a hyperactivity, particularly in muscles. It can lead to tetany, and there's increased protein binding of calcium, so it actually has a manifestation that can lead to hypocalcemia. Again, take a look at the full list of these disorders and read through the manifestations. I would say respiratory alkalosis is less likely to occur, and it tends to come on quickly and then usually is resolved unless you're dealing with things like encephalitis, or if the patient is improperly ventilated, that may go on longer. But stress, panic attacks tend to lead to this, but then usually are self-correcting. Can't stress enough, though, the importance of reading through this section, because on the exam, I don't just ask you to list a couple of manifestations, I ask you to list and then explain them. I usually give you the opportunity to pick which manifestations you want to choose from. So in other words, if I give you a disorder, respiratory alkalosis, metabolic alkalosis, I tell you to pick two manifestations and explain why they're occurring. That's the way I want you to be able to understand it. So I usually give you that option to kind of take the information as you've come to understand it. List what you think are the more profound. I've stressed through the PowerPoint and what I said here about what are some of the most profound things you see happening. A lot of these manifestations can be a little bit more on the minor side. I've picked out the big ones. But on the exam, I give you the option. But I usually ask you to pick at least two and then tell me why they're occurring. So by reading through the content of the chapter, that really can help you. Think about what's happening with excess hydrogen, excess bicarbonate. Think about the compensation that's going on. Is the kidneys compensating quickly enough? If we are in a panic attack, for instance, in respiratory alkalosis, the kidney cannot compensate by starting to get rid of a lot of excess bicarbonate quick enough to maintain it. This condition has to resolve itself at the respiratory level on its own. But if we're talking about things like encephalitis, we hope that renal function can kick in and start to help with that balance. So think about those compensation pieces. Think about what we can do to bring our body back to normal. That's the kind of question I ask. Sometimes just discuss the compensations that can occur and how they will work. And so you can't just say, well, it's respiratory alkalosis, so the compensation will be the kidneys. Well, how do they do that? What exactly is going on? The kidneys have to work to excrete more bicarbonate, leading to your urine becoming more alkaline. That process takes time and may not happen quick enough to get the patient out of a highly threatened state. Highly alkalotic can be severely damaging to tissue. So please take a look with that information. And that takes us to the end of the acid-base disorders.